Welcome to the Deep Dive, where we crack open clinical guides, surgical manuals, and dense research to bring you the high-impact knowledge you need, fast. Today, we're embarking on a very specific but critically important exploration, squamous cell carcinoma, or SCC. But we're focusing exclusively on its unique presentation and, well, its really complex management in the lower limb of the leg.
That's right.
When you hear skin cancer, you might think of a sun-exposed area like the face or hands. SCC of the skin generally sounds straightforward. But the sources we've collected, particularly an in-depth clinical guide detailing surgical strategy, immediately throw up a major red flag. They state that SCC of the leg is a diagnosis that masks a complex biological behavior. It's not your standard run-of-the-mill skin cancer here. Okay, let's unpack this. Why is this specific anatomical location, the lower leg, such a clinical conundrum? Why does it demand its own specialized approach?
It's truly fascinating, and the answer lies deep in the patient's history and the biology of chronic inflammation. Our mission for you today is to give you the surgeon's operational playbook. We're going to merge the pathology, the critical decision-making thresholds, and the precise operative principles required to tackle this site.
And it sounds like you really need all three of those things working together.
You do. The reason it's so complex comes down to three things: delayed diagnosis, significant ambiguity in how it looks, and frankly, a far more aggressive, varied metastatic potential compared to SCCs found elsewhere on the body.
That delayed diagnosis part is key. It implies that patients aren't immediately suspicious, or maybe even their doctors aren't. Let's start with the big picture, the epidemiology. It's interesting that we see SCC here not just because of the usual culprit, high UV exposure,
Right.
but often tied heavily to regions and populations where chronic inflammation and long-neglected wounds are simply prevalent.
That environmental context is everything here. When we pinpoint the specific chronic origins that make the leg a frequent hotspot, we aren't talking about acute trauma. We're discussing deeply entrenched, long-standing tissue injury. These are the chronic wounds that just keep turning over epithelial cells for years and years.
Okay, so like what? What are the big ones the sources point to?
Think of chronic venous ulcers, where the skin quality is already poor. We see it in old, unstable post-burn scars, even long-standing osteomyelitis sinuses.
So a bone infection that's literally draining out through the skin for years.
Years, exactly. And the sources even mention incredibly specialized, difficult conditions like leprosy-related neuropathic ulcers and historical radiation dermatitis.
These aren't just superficial scrapes. These are problems that can persist for decades.
Precisely. And this context, this decade-long process of cellular damage and repair, is what makes SCC here biologically distinct. And it dictates a crucial, non-negotiable clinical rule for anyone assessing these patients. Any non-healing ulcer on the leg that persists beyond 3 weeks must be considered malignant until proved otherwise.
Just 3 weeks.
That 3-week window is the immediate trigger, irrespective of how benign it might look.
That's a huge psychological hurdle, though. If a patient already has a chronic venous ulcer that's been there for 5 years, they might just attribute a new change to the old disease.
They do, or even their primary care provider might, delaying that suspicion far beyond that critical 3-week mark.
Which is why this is so vital to reset that low threshold for suspicion.
Absolutely. We need to remember that at the cellular level, the pathogenesis reflects sequential genetic injury. It's not a single lightning strike, it's a cumulative assault.
So tell us about that assault. What are the molecular events transforming these cells?
Well, it's multifactorial. You certainly have UV-induced DNA mutations contributing, especially in sun-exposed individuals. But crucially, you have the inactivation of the p53 gene, which normally handles cell repair.
The guardian of the genome.
Right. When that fails, coupled with a chronic inflammatory cytokine flux, meaning chemical signals constantly promoting cell division and damage, those skin cells, the keratinocytes, are pushed across the line into malignancy.
And that chronic inflammatory pathway is what really separates leg SCC from the rest.
It's the key differentiator.
Okay, let's transition from the microscopic to what you actually see in the examination room. How does this aggressive, chronically derived cancer physically manifest? Our sources introduce the classic triad of clinical presentation, which is sort of the foundational guide for initial identification.
The triad provides a necessary framework, especially since these patients often have complex medical histories that muddy the waters. The first element is the non-healing ulcer itself, often with telltale everted or rolled edges.
Everted. So the edge of the wound seems to be growing outward, like a lip, rather than trying to heal inward.
Precisely. It's a visual sign of malignancy pushing out rather than granulation tissue pulling in.
Got it. What's number 2?
The second element is an indurated base with surrounding hyperkeratosis. Indurated simply means hard, firm tissue deep beneath the ulcer. You can't easily depress it.
And hyperkeratosis is just that thickened, scaly skin around the lesion.
Exactly. And finally, the third element is variable pain, which is often disproportionate to the lesion size, especially in patients who already have underlying neuropathy, which can make the pain really difficult to parse.
What about those secondary signs that just scream high risk? The things that really push you toward an immediate biopsy?
You need a sharp eye for detail. Look for a foul-smelling, often purulent discharge, especially if it's connected to an underlying deep sinus or a bone infection. We also look for crusted plaques on the surrounding sun-damaged skin, and critically, the presence of satellite nodules.
Ah, so small, new tumor spots appearing nearby, which means local spread.
Right. And the physical exam is incomplete without a meticulous check of the regional lymph nodes, the popliteal nodes behind the knee and the inguinal nodes in the groin.
Now, this is where it gets difficult for the clinician, where that ambiguity you mentioned comes in. The leg is a master of mimicry. What are the close calls that can look exactly like SCC?
The differential diagnosis list is long and dangerous. We start by ruling out the mundane, like a standard chronic venous stasis ulcer or a diabetic neuropathic ulcer, but then we hit the tricky inflammatory diseases, such as a tubercular ulcer or pyoderma gangrenosum, both of which can cause these large necrotic ulcers.
And the really sinister ones are the ones where you could potentially miss a diagnosis that needs a totally different treatment.
Absolutely. While basal cell carcinoma is rare on the leg, the biggest fear is missing the amelanotic variant of melanoma.
Oh, wow.
This is a type of melanoma that lacks pigment, so it presents as a simple, non-healing pink or red ulcer. It can be a frighteningly close mimic of SCC. We also have to consider things like cutaneous lymphoma.
Which is why the sources are so adamant.
Yes. Due to this immense diagnostic ambiguity, biopsy is non-negotiable. Whether it's a punch biopsy for a small lesion or a wedge biopsy for a larger, deeper one, it is the gold standard that breaks the tie.
Here's where it gets really interesting. We have to pivot now to the ultimate high-risk scenario, the marginal ulcer SCC. This is a term you hear in oncology circles that carries a specific weight. For the listener, why are these tumors considered a completely separate, more dangerous category?
The marginal ulcer is a dramatic example of that chronic inflammation pathway gone totally haywire. It's named after the 19th century French surgeon, Jean-Nicolas Marjolin, who first described tumors arising from old burn scars. And the distinction is key. These tumors arise specifically from persistent epithelial turnover over an old, unstable scar, sinus, or chronic inflammatory site, not just previously healthy skin.
So the body's attempt to repair the initial severe injury actually creates the perfect hostile environment for an aggressive malignancy to thrive years later.
That's precisely the mechanism. And the sources confirm that these cancers are characteristically far more aggressive. They're often diagnosed late because the patient has just normalized the presence of the chronic wound or scar.
So by the time they present,
The tumor has deeper infiltration and a much higher propensity for nodal metastasis.
that tells me the management approach has to be fundamentally different. You can't treat a marginal ulcer like a low-risk SCC.
You cannot. The surgical rules are immediately upgraded. This requires what we call an aggressive margin. For a low-risk SCC, we might aim for a 1 centimeter clearance.
Okay.
For a marginal ulcer, you must always excise it with at least a 2 centimeter margin.
Wow, demanding double the margin immediately means you're going from potentially primary closure to almost guaranteed major reconstructive surgery, especially on the thin-skinned lower leg.
Exactly. When you take out a 2 centimeter rim of healthy tissue around a potentially large tumor, you create a substantial defect. We also maintain a very high index of suspicion for nodal involvement, and the entire specimen must be sent for meticulous, detailed pathology to confirm the true depth of invasion.
Okay, so once that biopsy is confirmed, we enter the clinical path of staging and surgical strategy. We need to know where the cancer is going. What are the foundational staging investigations?
Staging is vital because it determines our operative plan. First, an ultrasound of the regional lymph nodes is mandatory to check for subclinical involvement. We then use CT or MRI to determine the tumor's depth, especially its relationship to the underlying bone. We need to know if we need to take periosteum or even bone itself.
And for the really high-risk cases.
If it's a recurrent tumor, a high-risk case, or a suspected marginal ulcer, a PT-CT scan is indicated to check for distant spread.
What about the controversial area of sentinel and lymph node biopsy? When is that aggressive step warranted?
It's not routine, but it's strongly considered for tumors that meet the definition of high risk. High-risk SCCs are generally defined as those that are greater than 2 centimeters in diameter,
Okay.
those that are poorly differentiated on pathology, or, and this is critical, those that exhibit perineural invasion.
Let's pull that last term apart because those pathological elements are what truly dictate prognosis. When the pathologist looks at the tissue, what are the red flags that scream aggressive and dangerous?
They look for a trifecta of aggression. First, the degree of differentiation. Poorly differentiated cancer cells look disorganized and primitive. They've lost their normal function, signaling a much worse outcome.
And the second?
Second is the depth of invasion, how far down into the fat, muscle, or bone the tumor has gone. And third, that highly important one, perineural or lymphovascular invasion. This is terrifying because the cancer is actively tracking along the sheath of a nerve or inside a lymph vessel.
So the nerve is like a highway.
It's a highway. If the cancer is using that nerve sheath, it has a direct protected route to rapidly bypass local tissue barriers and potentially spread to distant nodes or even the central nervous system.
That feature alone must completely change the game.
It drastically increases the risk of recurrence and metastasis.
That makes the pathologist report the ultimate driver of the surgical margin decision. So just to lock this in, what is the surgical gold standard for wide local excision?
Surgery is the cornerstone, but the margins are tailored to the risk. For a low-risk SCC, the target is a minimum 1 centimeter margin of healthy tissue. But for high-risk recurrent or marginal ulcer SCC, we jump to that aggressive 2 centimeter margin, and the deep margin must be equally aggressive. Meaning it has to include the underlying fascia,
Right.
and if the tumor is deeply invasive or fixed, we must take the periosteum, the membrane covering the bone, to ensure clearance.
The moment you start talking about 2 centimeter margins and removing fascia on the leg, you've created a complex defect. This is where reconstruction planning shifts from an afterthought to an immediate prerequisite.
Absolutely. Reconstruction planning must be integrated early because leaving bone, tendon, or large vessels exposed is just not an option.
So what are the common reconstruction options when you're dealing with these substantial defects on the lower leg, where blood supply can sometimes be challenging?
The simplest route, if the defect is small and shallow, is the split-thickness skin graft. But grafts only work if they cover healthy tissue.
Right, they need a good bed to survive on.
Exactly. For deeper defects, especially where tendons or bone are exposed, we must use a flap. These are tissues brought in with their own blood supply. Options include the local rotational flap, which slides nearby tissue over, or the sural flap, which is very common and effective for the difficult distal third of the leg near the ankle.
And for the really big, complex defects.
For highly complex defects, we sometimes need a cross-leg flap, where tissue is temporarily borrowed from the opposite leg, or a free flap, which involves microsurgery to connect vessels and tissue from a distant site, like the back or thigh, to the leg defect.
That's a sophisticated hierarchy of surgical solutions. Let's revisit the lymph nodes. If the initial ultrasound or physical exam is suspicious, what's the path?
Suspicion of nodal involvement means we need confirmation. Clinically palpable nodes warrant a fine needle aspiration cytology, or FNAC. If that FNAC comes back positive for cancer cells, we proceed immediately to a therapeutic inguinal or popliteal lymph node dissection, removing all the involved nodes.
That's key therapeutic, meaning treating existing disease. Is there a role for prophylactic dissection, just in case?
No. The sources make it clear that prophylactic dissection removing nodes without confirmed disease is generally not routinely recommended.
Why not?
Because of the associated morbidity like chronic swelling and lymphedema, which can be severe on the leg. We act only on confirmed disease, relying on diligent surveillance otherwise.
And finally, for those cases where surgery can't get clear margins or the disease is simply too advanced, what role do non-surgical therapies play?
Radiotherapy is the primary non-surgical tool. It's used in specific situations. When clear margins can't be achieved surgically, or if re-excision is technically infeasible. It's also often used as an adjuvant therapy following surgery in cases with confirmed perineural invasion. And chemo. Generally, chemotherapy sits on the sidelines here. It has limited value but is reserved for advanced or metastatic SCC that is unresponsive to local therapy.
The intensity of the management implies an intense follow-up period. What is the surveillance schedule required to ensure this cancer doesn't sneak back?
The follow-up protocol is structured and highly intensive in the early phase, which is when the recurrence risk is highest. It requires 3 monthly visits for the first 2 years, checking the primary site, the nodes, and the skin in general.
And then it drops off.
It drops to 6 monthly visits for the next 3 years. Only after 5 years of clear scans do they transition to annual surveillance. This aggressive monitoring schedule is a direct response to the complex biological behavior we discussed.
That intensity really underscores the difference between a high-risk leg SCC and a simple excision on the arm. So as we wrap up this deep dive, what are the 3 essential takeaways you should have committed to memory? First and foremost, any chronic leg ulcer, especially if it's on a scar, a burn site, or a long-standing sinus, must be treated as malignant until proven otherwise. Reset your threshold for suspicion to that critical 3-week mark.
Second, remember the pathological red flags that dictate the path ahead: depth of invasion and especially perineural spread. These are the indicators that tell you the cancer has found its aggressive highways and requires the strictest protocols.
And third, recognize the marginal ulcer SCC as a different beast entirely. It's driven by chronic inflammation and demands aggressive treatment, those mandatory 2-centimeter margins, and immediate integration of reconstruction planning.
What's really fascinating here is seeing how persistent, low-grade trauma and chronic injury provide the fertile ground for those molecular changes. It fundamentally alters the nature of a disease we usually associate just with UV exposure.
A powerful lesson.
It teaches us about the danger inherent in unchecked long-term inflammation.
We discussed how persistent epithelial turnover over a scar or sinus leads to the aggressive marginal ulcer. So here's a final thought. What does this tell you about the body's long-term immune and repair response to deeply entrenched chronic inflammation, and what other conditions out there might share that dangerous path? Something for you to mull over as you continue your own learning.